So I think we're going to get started. Is this on? I think we're going to get started. Can we have everybody come gather in the room? Hi everyone, my name is Natasha Prodenbala. I'm the Chief Nurse and Professional Practice Officer in the Ministry of Health. Welcome to today's session. I'll be moderating the session, keeping everybody on time. If you have any questions, just let me know. So this session is titled Teaming Up for High Quality Care. And I also wanted to take time to just acknowledge that we are on the unceded territory of the Coast Salish peoples for this talk, including the Musqueam, Squamish, and Tsleil-Waututh. I'm going to call it MST now for short. So I'm just going to introduce the first speakers, creating an integrated health service plan for the Thompson region, and each of the speakers are going to speak for 10 minutes. We'll have 8 minutes for questions, and then 2 minutes for transition time. And they are going to be introducing themselves. Thank you.
Okay, thank you so much for having us here today. We'll start this off here to keep us on time. So with our time, what we'd like to do here is do a quick introduction of ourselves, share with you the Thompson Region Collaborative Services Committee vision. So those not familiar with Thompson Region, that's Kamloops, as well as about an hour around. So we have a number of rural communities included here. We really want to focus on 5 steps related to service planning that I think are useful that you can bring back to your own community, work, and related to potentially service planning, but other areas as well, and involves team input. And then we'll share our lessons so far. So we'll do a proper introduction, but there's no conflicts to kind of speak of at this moment in time. It's like, who's who here? Well, we're out there, but we wanted to have this both for those that are kind of not in the room or following later on, who's speaking, and then also to just acknowledge that we are here on behalf of a collaborative table, and so we were the 2 representatives who were able to make it here, but we have a number of our physician leads who participate. We'll put up a list later, First Nations Health Authority, as well as Interior Health Administrators, GPSC and Ministry, all part of this team. So my name's Monique Walsh. I'm the Executive Director with the Thompson Region Division, and have been working with the division for 6 years, originally from the East Coast, so a maritime girl at heart. One of my things I wrote in the session earlier is that I have knowledge about fiddling that I'd love to share.
Hi everyone, my name is Sue Lissel. I'm a network lead with the Thompson Region Division. Been working with the team for about 1.5 years, and I have no fiddling knowledge whatsoever. From the prairies, and have been living in Kamloops for about 13 years, and so very happy to be a BC person now. I'd also like to introduce you to Dr. Nelly Oelke, who is half a world away in the Middle East at another conference, but has been really instrumental in introducing us to some of the process that we've used.
Great. So for those who are familiar with the collaborative services model, these committees have been around for about 10 years. And what we did for the last year is focus on this vision where we were committed to engage broadly across our region with partners and stakeholders to work on an integrated health service plan. And that was really important to us. We were not a primary care network first kind of wave community, but we didn't want to just wait around. And so this is sort of our journey of what we've done over the year. The committee seconded the CSC, so this is all we've talked about for the last year, and really looking at developing a shared vision that crosses over a number of the entire spectrum of care, and that it involves multiple inputs. So we focused on that, really networking of our patient medical homes, community health centers. We wanted to include the voice of our subspecialists. We have many in the region, as well as our specialist colleagues. And then our community health providers who are non-allied health were really critical. So we sought out the community pharmacists, the allied health within the region, because our physicians were saying these are part of our networks that we are using in our referral and our team-based care. It's not necessarily only with health authority. It was really key to that our plan was community built, so we went and met with a number of local health tables that were either in existence, had been in the past, or supported our communities to establish community health tables that have many variety of representation, and put together some strategic planning related to that. And then ultimately we wanted our decisions to be data informed, which proved to be a little bit more challenging. So I'm going to pass it over to Sue to walk through the 5 steps.
So you can imagine when you're trying to do comprehensive integrated health service planning, you need to think broadly. And so we used the BC Health Quality Matrix as a foundation to make sure we were very conscious of the entire spectrum of care. So looking at the staying healthy, the getting better, living with illness, and end of life as well. And then we found Nelly. We were really looking for someone with a health service planning background. Originally, we were really focused on data, and we were introduced to Dr. Oelke through our Thompson Medical Alliance Interior Health Research Partners. And she has proven to be both a wealth of expertise, but also what we didn't realize we needed was a process. And so she introduced us to the deliberative dialogue, which I'll speak about a little bit. The second step was, who are we going to have around our table? And the answer is just anyone we can possibly get there at the same time. So we have used our CSC as our special task force and have been meeting with them twice monthly over this year. And then we've also put together 10 specific sessions around certain areas of care. And so you'll see them up on the screen there. And at those sessions, we made sure we invited sort of our special guest experts. So that's specialists, physicians with specialized practices, community members, community service members, and also all of our allied health. So that's a watermark of our region, and you can see the members of the CSC on the left there. So many IH partners, some First Nations Health Authority partners, our GPSC liaison, lots of our division team, and then Nelly, many of the people I just mentioned in terms of those administrative and community experts, both clinical and non-clinical. So data, very difficult. But what we wanted to present before each of these sessions was something that everyone would have the opportunity to go through prior to the discussion. So we did ask for high-level summaries of the current state of care. So this could include relevant summaries from documents, quotes, statistics, qualitative and quantitative information. We wanted to know where this came from, so if we needed to reference, we wanted to know who was involved, and we wanted a bit of a nod to the future state. So what exactly, if we had all the time and resources in the world, what would we want to see? The sessions themselves were very structured. They're facilitated. It was a repeatable process that we did the same every time. We had different amounts of time to do this, but the sessions followed the same flow. So presumptively, everyone would have read the data, but as it turned out, not everyone had read the data, so it was available within the session itself, which didn't prove to be necessarily a barrier to great information. But the first part of the session was a very quick 5 to 10 minutes about the ideal state. So 0 barriers here, dream big, no funding or resource challenges. What would you want the ideal state of care to be? The second question was data-based, and this is where we realized really quickly that the data was complicated. It was maybe not relevant, it was maybe not up to date, it was maybe incomplete, it wasn't what the experts in the room actually knew from their lived experience providing care. So we know that's a huge challenge, but it did provide wonderful conversation and lots of challenges there. Quickly in these sessions, we moved to action. So after we talked about all these issues, it was the question to the group, what can we do? What are the actions? What are some actionable things to get us to the future state? And once those were down on paper, and you can see there, it's just many flip charts, we collapsed those, eliminated any duplicates, and brought them to the front of the room, where people were then asked to vote on their priorities, short-term, medium-term, and long-term. And you can put all your dots on one action, you can put none of your dots on any of them if it wasn't what you really think should be reflected. So we had, I don't know, 60 to 70 actions. So how are we going to do that all? We know we can't. But based on the groups, we know there are groups working on these things because the key actions came from them. So we're currently theming, we're trying to timeline some of these things and identify who is actually responsible for the work. We're transposing these plans using the measures that our partners are already working with, so the PCN and the SCSP measurement. We're checking back in with our members, we're reaching out to our local health tables rurally, we're trying to develop sort of a representation graphically of what this looked like, and of course, lots more work to be done.
Great. So some of the shared lessons, one, we've spoken a little bit about the data and how data is understood or misunderstood or what's missing or how do we share this. We also collected all of the actual 100-page reports through the data and have a shared repository online with those, and then the summary pages as we go forward. But this will be an ongoing piece, and those who have done PCN work or other kind of initiatives through the healthcare system know that typically you do need a data group or working group to focus and continue pushing that. So that'll be a big piece of our work going forward. The one thing I really want to share is just how energizing this process is. For those in the room who go through facilitated sessions, you think, yeah, these are all steps we do. Of course we would do these things, but to actually do them very, very focused, strategic, and timelined is so powerful. And Nelly's work, Dr. Oelke's work is through research and published as well around integrated service planning and applies deliberative dialogue. And so I encourage you to use that potentially as one of your structures or mechanisms. And through that engagement is really involving team, multiple voices, and moving quickly. So for example, the topic of urgent care, people spend their life around how do we network urgent care and think about urgent care. And when you're given an hour to make a game plan on it and very focused, we arrive with some really quality outcomes for that. And then we really want to involve multiple perspectives, and that includes both the opportunity and the challenge of doing so. And so I think it fits within the session. We're going to end here for questions, but the opportunity to really go broad, and our engagement has shown that. So when we end at the end of the day, part of it is now establishing the process and the mechanisms that attach all of the working groups, all of the health tables, all of the community health centers in and out of the CSC so that our plan is comprehensive. We don't get overwhelmed, but that we're well linked together, and that we've set the year, so we finish in March. So we'll see where we get to at the end of that. Maybe next year we'll be able to come back with our graphics. So thank you. 10 minutes goes very quickly, but we're excited for the questions. Okay.
Your third bullet on your last slide.
Yes.
That's something we all struggle with. Were there any techniques or tricks in your specific exercise that were effective in doing that?
Yes. So the first thing I think I would just say around that is that recognizing that it's not one group that's doing the work. And so what we did is through the action, obviously we prioritized, but then as we were theming, we land on one action, which has multiple actions to it. So the first meeting, we spent an entire meeting unpacking this one action and landed with 10 actions around it. So that was not maybe a great example of how we overcame that. But we realized quickly we can't do that with each one. So how are we going to move forward? And so our suggestion was to create this process, and it's a memorandum of understanding with the groups who are actually working on that, who then unpack the actions. And so when you streamline it back into a plan, it's not 100 things to achieve the one. You can still say really narrow, but the team that works on the 100 is then responsible for their ability to go. So I don't know if you can get away from all of it, but that you kind of bridge who's doing which parts. Mm-hmm.
Any other questions? Can I just remind everybody, this is being live streamed, so that's why we're asking for Mike to use the microphone.
Great. Oh, I think we need a mic over there.
Great presentation. I just wanted to know what you mean by good data is difficult. Maybe you could just clarify.
Well, I'll give you one example. When we look at CTAS 4s and 5s, and we look at, okay, we're trying to remove these CTAS 4 and 5 visits, or the majority of them that are showing up in the emergency department. The data reads on a sheet that's produced, right? And it says 35% of the CTAS 4s and 5s are unattached. So when you read that, you're already framing your actions related to how will we address these unattached patients, which we could flip that and say 65% of these patients who are showing up in the emergency department are actually attached. So do we have an attachment problem, or do we have more of an access problem because our panels are oversubscribed? So the idea of good data, that's one piece of actually how are we framing the data and how does it shape our actions. Another one is that we had clear missing gaps. So TransCare was a giant gap of actually some really good statistics and numbers behind it. And some of the information around data is just how is it interpreted once it lands on the reader, and so you often need to unpack that, and in a quick kind of summary there's not an opportunity to do that. And the last point about data is that you can't always get your hands on it, right? And so how are you asking for it? How quickly is the turnaround? And so we were doing this over summer months where we were asking people for data, and so it was over a period of about 3 months where we were kind of calling up and like, you remember you promised you were going to send this report. Hey, I know you're on holidays. Can you ask someone? So it's even just like the physical delivery, not even what arrives sometimes. Yeah.
Time to just a quick follow-up to that. I just wondered whether through that process you identified some data that you actually would have to collect yourself to make sure that you got the data that you were actually looking for and that the quality of that data was to the level that you were expecting.
Yes. One of the things that I think is most powerful is actually like physician panel practice data, or EMR data, right? And so when we look at how are we reviewing that information, we've identified some gaps that are really within the wheelhouse of divisions. Specifically, I'm speaking of to support our members to move towards. So similar coding, right? So how are we may not have a provincial standard on one component, but we could definitely establish a regional structure for coding. So we found that the physicians in the room were coding things related to mental health in 8 different ways. How are we actually then using that? Because it might not show up as a priority, but that's because it's across 8 different codes, right? So something like that, that's really actually concrete that we can tackle. And then there was other parts where we've identified data. So for example, is there anyone from the ministry in the room? Sorry, but we, not being a primary care network, there's no additional support, right? So, I mean, not that we won't become one, but throughout this year, so we asked for our gap analysis data from the ministry, but due to capacity, it wasn't kind of a priority because you're not PCN. So even though you're planning, you don't have access, right? And so some of it is within division, some of it is health authority, some of it is with our partners, and how do we actually come together to make sure that the information is present, relevant, timely, and there's someone available to speak to it. And I think our best example was with population health, who really went through data, who prepared it, was timely within Interior Health, timely showed up, talked about it, reminded us over time to come back to it. Yeah, so there's some good examples as well.
Great. Thank you very much.
And the last thing I would just say is this photo I just absolutely love, but if anyone knows Kamloops, we really timed our photo shoot here because it's not usually that green, but but I do love this shot, so thanks.
Thank you. Thank you very much. It's a hard job. Yes?
We've got a bunch of people looking for seats.
Yep,
If
there's
you wouldn't
seats up
mind
here.
scooching in, I know it's a little tough, but we've got some folks that would like to sit down if we
There's
can.
some at
That'd be
the
great.
front. So I'm just going to welcome Heath to come on up and do the second talk of the session.
For joining us today. And I say us because, as you can see by your program, there were meant to be two of us here today, but unfortunately, due to unforeseen circumstances, Peggy was unable to join us. But I do want to acknowledge Peggy and all the hard work that she's put in to this project over the last year as the lead for our implementation. And fun fact, she's actually born and raised in Labrador, Newfoundland, and I'm born and raised here in Burnaby, actually. So that explains the flags, because I think it's a cool background to our story that we do really tend to balance one another out quite well. And who knows, maybe it has to do with where we're from, maybe not. But if anyone's wondering why the military is here, or why the military from Alberta is presenting at the BC Quality Forum, I encourage you to ask afterwards, but I think I only have about 9 minutes now, so I'm going to try and get through this. My name is Heath, and I have the great fortune now to be in my 4th year as the manager of a very unique primary care clinic and network in Alberta and the Northwest Territories, serving about 7,000 military members. And today I'm really honored to be able to talk to you about the process that we've gone through over the last 3 years in our quality journey, and then hopefully we can talk even more about why quality improvement is such a valuable vehicle for leadership development, which of course is important to us in the military, and also how external partnerships, while they can be really valuable in helping you succeed in a quality improvement project, we found they can also be very valuable in the building of a continuous learning culture. So hopefully we can talk more about that. Clearly, I don't have any commercial interests. And in terms of what is IAMCare, or the integrated access model, it's essentially a project that we've been engaged in to reduce wait times and improve quality of care by focusing on decreasing barriers to access, improving interdisciplinary collaboration, and continuity of care. Now, 2 of the really cool intangibles of our quality journey we found is the leadership development opportunity the environment has provided to some of our junior nursing officers in particular, who some have gone now through the crucible moment of leadership, tears and all, through the last 3 years. And we think they've come out the other side better for it, because as they say, experience is the best teacher. And secondly, we are really proud of the external relationships we've built that have helped us embody the concept of lifelong learning as leaders, added credibility to the project, and really inspired us in a lot of ways, because I find QI to be contagious. So we're going to talk about that a little bit also. As for the context in which this work takes place, I think we need to start with the Canada Health Act. So some of you may know, but the Canada Health Act excludes 4 types of Canadians from provincial and territorial care. They are Indigenous living on reserves, RCMP, federal prisoners in federal penitentiaries, and the Canadian Forces. Of those 4, the Canadian Forces is the only one with its own regulated and governed, administered healthcare system. So, in a way, we are Canada's 14th healthcare system, the Canadian Forces. And what's really cool about our system is that we are a national primary care network. So we have, across the country, the majority of those little bullets are clinics, and we're all in one PCN, and we all are on one EMR. and we can actually deploy, yeah. Yeah. All right. Yeah. And we can actually deploy anywhere in the world with a data extract to continue providing care to our patients anywhere, anytime. So that's cool. This is us, more specifically, in Edmonton. This is the clinic that I work for and have been for the last 4 years. This is our old building after Canada Day barbecue. But what I think I need to point out here is that in Edmonton we have 4 departments: primary care, mental health, diagnostic therapeutic services, and support services for HR, finance, etc. And what's really cool is that we're a blended workforce. So you'll see in there, me being the military working in this system, I'm actually outnumbered by civilians. So between Yellowknife, Calgary, Suffield, and Edmonton, all those clinics, we have about 200 people. And it's about a 70-30 split between military and civilians, with the majority being civilians. And of those, there's 2 different kinds: public servants, so federal public servants, and third-party contractors, which are the majority of our doctors, clinicians, technicians, etc. So last year, we were actually very fortunate, and we got to move into a new primary care clinic, and all of our services are now under one roof. We moved in about September, October, so we haven't had a chance to get outside. It's pretty cold in Edmonton, take a photo, but we're going to get to that probably in the spring. But we're really, really happy that this is our new home. Now, people often ask me what kind of clinic you work in, and how would you describe it? And the easiest way I would describe it is that we're a primary care clinic on steroids. Okay, we have all of this under one roof. We are a primary care clinic with a CT scanner, unheard of. We have X-ray, ultrasound, lab, pharmacy, our own biomedical technologist, mental health, psychiatry, psychology, physiotherapy, and a lot more. So what did we do? Well, when I first came into the position in the fall of 2016, I had just graduated from UBC, the MHA program, and I had the great fortune to have Christina Kraus as my teacher, professor for quality care. And she shared with us a story about a hospital in the Okanagan who went through staff, patient, family engagement exercise to improve quality. And essentially, some of you may be familiar with it, they went around and they had people write on their hands what's important to them on a Sharpie, and then they made a video montage about it, etc. So I thought that was really cool, and therefore we took our own little spin on it, and we created the All Hands on Deck initiative. And what we did is we actually cut out like 200 hands from construction paper. Even some, you can see at the top right, were like the Vulcan hand, the normal hand. So we have some, well, you can also see one of those arms is Oprah right here. Just saying, you get healthcare, you get healthcare, you get healthcare, you get healthcare. So it was a lot of funny hands we got back, but long story short is we used that, did some open space exercises, had everybody involved, and developed our mission, vision, values to try to set the pathway and guide us for the next few years. And what's important here is our vision to truly become an interdisciplinary team, recognized as a national leader in the provision of safe, comprehensive, and evidence-based primary care. So it's moving from a multidisciplinary team to a truly interdisciplinary team, which is a lot easier said than done. After that, we focused on governance. So we created our own mini patient safety quality care council there with patient safety, patient engagement, patient privacy, workplace wellness, occupational health and safety. So all kind of things you would see in a hospital, but in a primary care clinic. And for me, I see this as the way for the organization itself to self-actualize, because this is how quality improvement can now be done and supported, and it's more of a formal process. All right, so now this is 3 years in 3 minutes. I'm going to try and get through this pretty fast, but what we did, and after the groundwork was laid, is we partnered with Health Quality Council Alberta, which is the sister organization of BC Patient Safety Quality Council, and we partnered with AIM Alberta, an arm of Alberta Health Services, which stands for Access Improvement Measures. So Health Quality Council Alberta, we partnered with them so we could actually put more tools in our toolbox as it relates to QI, so increase our capacity to lead and sustain quality improvement in our workplace. And then we partnered with AIM because AIM actually has as a mandate to improve the operational efficiency of clinics in Alberta. And they have all the tools that you would need to do that. So we partnered with them. We process mapped, identified pain points, and we focused on TNA through small tests of change, PDSAs, all that good stuff. And just quickly to explain here, so CDU A, B, C, and D, we have 4 care delivery units in the clinic, and every care delivery unit has patients rostered to it and has doctors, nurses, PAs, admin staff, and nurse practitioners. So it's kind of like a primary care clinic in a larger clinic, but there were no ancillary services in the CDUs. So there's no mental health in there, no physio in there. It's basically your walk-in clinic, and then instead of being referred out, you're referred upstairs or down the hall, etc. So did a number of PDSAs. There was a lot of change that happened, but in the interest of time, I'm just going to highlight one of the most important ones for us, which was we were able to integrate mental health and the CDUs together to increase the CDU's capacity to provide care to their patients as it relates to mental health, because as we all know, a lot of patients presenting these days, there's a very high prevalence of mental health. So we're happy with that. This is how we're going to know if change is an improvement. Basically, our wait times down, our patients and providers happier in their workplace, and our safety incidents reduced, etc. So to do that, we're going to be evaluating our model, and once again, we partnered with APRSU, which is an arm of the U of A, and they are the provincial body for the use of PROMs and EQ5D in the evaluation of any primary care clinic, model, etc. And here's a quick video testimonial from one of our mental health nurses.
My name is Captain Boyce, and I am a mental health nursing officer here in Edmonton, Alberta. The main point I would like to highlight with respect to this new model of care is the ability for a member to access a mental health nurse almost immediately. This allows the nurse to provide the member with psychoeducation, medication management, problem-solving skills, crisis management, as well as the ability to access any other appropriate care that they may need within a timely manner. No member is ever turned away.
Any questions?
Thanks so much for that. You mentioned moving from a multidisciplinary team to an interdisciplinary team. Right. Can you help me understand in your words what the difference is?
Yeah, I can try. So when I think of that, I think of relationship-based care. And one of the key, if you're familiar with the Google Aristotle project, one of the key factors that defines high-quality teams is psychological safety in the workplace. So that's breaking down barriers, having people come to a common understanding, and trying to dilute power between teams. And as we know in healthcare, the power balance is normally in favor of the doctors. So finding a way to dilute that and have it as more of a team approach, where you have more people at the table and their opinions are valued, that's kind of what we're talking about. And it's, like I said, a lot easier said than done, but we're working on it.
Hi, Heath. It's Dwight Ferris, Infectious Diseases in Kelowna. How do you integrate the specialist care of patients? So you identify someone has a more complex need. Right. Do you integrate into the Alberta Health Services, or how does it work? Yeah,
so Alberta has recently developed strategic clinical networks that some of you might be familiar with. But we're actually very fortunate that not only do we have all the primary care resources in our clinic, we actually have a specialty clinic. So what we do is we have specialists come in, and they're actually seeing our patients in our building. And then they're plugged into the civilian system to book an OR date. But that's obviously doesn't cover everybody. And therefore, if we can't provide it in-house, we coordinate it externally for the member, and we pay as a non-provincial buyer. So we actually pay more money for healthcare than the average Albertan. Yeah.
Thanks very much for your presentation. It was very informative. I'm over here.
Okay.
I saw when you were going through the governance structure that you had a patient, I think it was a patient safety advisory council.
That's right.
Could you please explain how that integrated into your governance and what the role and functionality of that was? I'd be interested to see how that works in your setting. Thank you.
Yes, for sure. So I think it's a patient engagement and advisory team, and underneath it, it has patient safety, patient privacy, and patient engagement. One of the most difficult things we've realized with our patient population is getting them to want to provide feedback to us and getting them engaged in a meaningful way. And what we found a lot of the times is the best way to make them happy is just have them seek or have them access care quicker. So wait times is often the number one thing that we get, which is why we're focusing on it so highly. But from what I know, if you're going to have a governance structure, you need to have a patient voice involved in that governance structure. So that was the way for us to kind of support that. And then we basically made people responsible for it, gave them a terms of reference, and then had them follow an action plan that involves going out to units and talking about what our services are offered, but also how they can help us make them better.
Any other questions?
Okay, thank you.
That's great. And I'll have the next group come up.
Good morning, everyone. There we go. I'm Kim Merkli. I'm a family physician and the medical coordinator at Pender Community Health Center, and I'm presenting today with Emery Prette, an RN and now a coordinator at Pender, and Emily Daft, an RN and now a coordinator at Connections Clinic, and Miriam Kuchek is here as well. She's our clinical resource nurse. We have nothing to disclose. So we're going to talk about team-based care, and this is nicely linked with Heath's presentation. When you look at the literature for team-based care, it tells us that we can increase access, we can increase quality of care, and we can increase satisfaction for both patients and providers. And we were also particularly interested in the access piece because of patients like Steve. So Steve is someone that had unthinkable trauma in his childhood and developed a severe opiate use disorder. He ended up homeless in the downtown Eastside and really struggled for a long time. Finally decided he wanted to make a change, walked into Pender asking for help. And the response he got was, "Sorry, we're at capacity." He thought, you know what, I'm out of here. He went and used, and he overdosed. Fortunately, he survived, but instead of ending up on life-saving opiate agonist therapy that day, he ended up in the emergency room. So our idea was, instead of turning away 3 to 4 patients like Steve a day, maybe we can implement team-based care and increase our access and take on more new patients. In order to do that, we had to define team-based care for us. We're hearing a lot more about it. It's come up at the Quality Forum already, and there's lots of information available, and there's lots of overlying concepts. So we brought out 6 that were meaningful for us. And the first one is interprofessional. And again, I completely agree with Heath. It's not just about having multiple disciplines under one roof. It's about the complex process of creating a highly functional team. And the next is person-focused. This builds off of a patient-centered approach where we step away from the disease-based model and we're looking at one's experience with their health over their lifetime. And this can be applied to our staff and team members as well, because we all know it's equally important that we're healthy and happy at work to be productive and efficient. The next is relationship-based. Again, the significance of the patient-provider relationship is well known, and we also need to invest in building trusting relationships amongst the team members. The next is redistribution of work. So this is the idea of sharing the responsibilities of care amongst all the team members to be able to provide the highest quality of care possible. And pre-visit planning. For us, this looked like daily morning huddles where we reviewed who was coming in, what their needs might be, and who would be best suited to see them to meet those needs. And finally, care coordination. We all know about all of the work that happens behind the scenes for our patients. So this is about creating an empowered, critically thinking team that can get that work done in the most efficient way possible. So we started by recruiting a team. So the 3 of us and our social worker, Terry Dean, and intake worker, Faiza Khalil. And we got EMR to give us one screen view so that we could all work together from one view and communicate more easily throughout the day. We tried to find space. We do not have a nice, big, new, fancy space. So that was more challenging than you might expect. And then we got started, and it was real trial and error for us. We knew that we wanted to utilize social work more. We knew we wanted to utilize nursing's chronic disease management more. And we started collecting data for about 7 weeks, which Emery's going to present next. And we did PDSA cycles once a week to see if there was any way we could improve our process.
Great, thanks, Kim. So here on this graph, we are talking about the average amount of clients seen a day per physician. So the orange column here represents the average amount of clients seen prior to our pilot. The red represents the average during the pilot, and the blue represents our max or our peak amount of clients we were able to see, which is great. So just in that short amount of time that we tried team-based care, we saw a 36% increase in the capacity to see more clients like Steve, which is great. And what we believe is the peak or our max amount of clients that we were able to see is actually our potential in our clinic, especially as we continue to roll out team-based care to the rest of the team. On this slide here, we're talking about something called related bookings, which is technically a link between two disciplines in our EMR. So if we wanted to see who Steve saw at our clinic, we could see that, okay, Steve came in and saw me, Emery, a registered nurse, but also linked to see Dr. Merkli, who also saw him in the day. But what this also represents is something called warm handover, which was one of the biggest learnings for us in this pilot. And warm handover is a face-to-face discussion between two team members in two disciplines, usually resulting in a same-day visit. So it's knowledge translation, and it's building trusting relationships within the team. And prior to this model of care, this pilot, a lot of the care we were providing was very task-based and pretty disjointed from each other. A lot of the time, if someone came in to see me as a nurse, but we figured out, hey, you know what, you would benefit from a social worker, they would have to wait a couple days to see a social worker, or we'd have to book them in the next week, which wasn't the best model of care for our patient population. So what we were trying to move towards is more of a seamless transition between disciplines for same-day visits. Yeah. So some things that we realized during the pilot was we needed to try and standardize some of the visits. So we created 6 different templates for some chronic disease management visits. And these are utilized by registered nurses, physicians, and nurse practitioners in our clinic, and they're actually starting to be used in some other primary care centers in Vancouver Coastal Health as well, in downtown Eastside, which is awesome. And these were good just to standardize the visits, but also good for people like me. And I had never done, a methadone assessment before doing team-based care, so it was a good prompt for me to remind me what I was supposed to be doing. We also created some workflows, so a workflow on how to do the opiate agonist therapy assessment with nursing and prescribers, and also created a chronic disease management workflow with team-based care, which looks something like this. And this was good just to introduce the rest of our team to how the flow works, especially as we started to educate and roll out team-based care to the rest of the team. And yeah, our lovely CRN, Miriam, is here, and she's helping to orientate the rest of our team members, and we're starting to do it every day of the week. And so we're starting with, learn about it, so we are presenting on it in some of the team meetings we're having and having them read some of these workflows, and then they shadow us, and then they do it themselves. Pass it on to Emily.
Here we go. So a little bit about what we learned. We learned that we can, in fact, implement team-based care and that it does increase access to care. This is especially important within the context of the current opioid overdose crisis and ongoing limited access to primary care in the downtown Eastside. We want to talk about the value of pre-visit planning, which we adapted from other programs that were doing weekly visits. This helped meet the needs of our population, who weren't always great at booking appointments well in advance, and we were often seeing them on the same day or walk-in visits. They were also significant in task delegation, so we could ensure we knew who was doing what and the appropriate professional was seeing the client, and also allowed us to review the assessment needs and become more comfortable with chronic disease management and our assessment skills. I think we all know about the importance of psychological safety. We were able to establish trust and positive culture within our team that allowed us to ask questions and challenge each other to make improvements to our program. These created opportunities for growth and development and ultimately improved client care. This was also essential in our local decision-making and PDSAs. This was an ongoing process, not just within our pilot project, but continued long after. The PDSAs allowed us to take frontline ownership and implement changes at a clinic level without having to go overhead and need overhead approval. Also, Emily spoke to the importance of warm handover, not mentioned on our slide here. So in terms of feedback, we felt productive, we felt successful, and we were having fun at work. We got to know each other better, and we got to know our clients. We weren't having to repeat ourselves over again, which were meaning we could see more clients and offer more client-centered care. Within team-based care, we moved away from task-based work, which was especially important for nurses in feeling job satisfaction. Well, not just nurses, everybody felt job satisfaction, but we moved away from that task-based work. This meant we were more invested in the week we were doing. We had improved relationships with our coworkers and our clients. Additionally, our clients gave us positive feedback. They were appreciative about reduced wait times. They also liked having more providers that they could go to for support instead of just having a single MRP. In terms of our challenges, space was undoubtedly a challenge in the clinic that we were, our existing space that we had. We needed co-located charting space and assessment spaces so we could all be working at the same time. We had a bit of a culture shift. We were all really excited and invested in team-based care when we got going, but when we went to move that out to the larger clinic, we wanted to make sure everybody was on board and that we weren't pushing them into a new process or program that they weren't quite ready for. In terms of staffing in the downtown Eastside has been an ongoing challenge across the sites. So we wanted to make sure we had team members who were working on the same day and could work together consistently to provide consistent patient care. This is often difficult because a lot of our staff tend to be part-timers. Our workflows, we adapted and developed new workflows, which was a process in itself, but also implementing these to the larger clinic did pose some challenges as well. And our EMR limitations. We talked about having to put together a new view for our clinic, but we also had to come up with those templates and workflows as well. So what we learned, we are convinced that by implementing team-based care that we can increase access, we can increase quality care, and we increase satisfaction for both our clients and our staff members. We also have a YouTube video if you'd like to check out a little bit more about what we're doing. Otherwise, I think we're ready for some questions.
Thanks for your talk. I'm wondering if you can chat a little bit about pre-visit planning.
Sure. So this is where we're trying to take that proactive approach for our patients. And ideally, in some places, you can do that a week in advance. Again, for us, we had to adapt that because our patients tend to show up the same day that they're being seen. So you're reviewing all their screening. Are they up to date? You're reviewing if they need medication refills, if they followed up with a social worker like they said they were going to do. So just kind of checking in on everything that's outstanding or that you left for follow-up last time and being able to be proactive about that. I don't know, does that answer your question?
I think as nurses, for us with the pre-visit planning, a lot of that was the assessment pieces. What did we need to check on? What was needed to make sure that Kim had the appropriate information as an MD, and we could support her as a nurse.
I have a couple of questions. When you talk about not so much task-based work, can you explain what you mean by that? I think what you mean is you're not just doing injections and that sort of thing. You're doing potentially more counseling or chronic disease management.
Sure. Yeah, so I think when we started doing more team-based care, most of the nursing visits we were doing was like someone coming in for wound care, we do the wound care, and then they go. Okay, here's a good example. Someone comes in for wound care and we find out, oh, they have cellulitis, so they need to see a doctor. So then we have to wait for a physician or a nurse practitioner. So maybe the person goes back to the waiting room and waits there until a physician can see them. And they see the doctor, then they need blood work. So they go back to the waiting room, wait again to have blood work done. And we can do all of that in one nursing visit pretty much and have a doctor come in, So it's a lot more efficient for that client. You know, you're there in the room, you're getting your wound care, your blood work, and seeing a physician. And with our patient population, a lot of them, they don't like to stick around in the waiting room and wait for a long time. So it's just better quality care for them. Yeah.
I have a nurse. I'm a family doctor, and I have a nurse in my office, and this is also what we do. And I think one of the challenges for physicians working with nurses is to get beyond just doing task-based work. So thank you for presenting. The other question that I had was, do you guys do any of the screening, pre-visit planning, or is it mostly the physician?
Yeah, we're learning and we're changing, I would say, as we continue to grow in the clinic. But I would say, kind of speaking to what you were saying before as well, just breaking down that hierarchy and having it less, top down, physician down, and more of a team approach. We don't have a social worker up here now, but we also have a social worker on the team. So it's a way for the whole team to get together and talk with the clients coming in and not just have it be the physician. Yeah.
Thank you. That's a great presentation.
Hi, thanks for your presentation. I work in a primary care clinic in North Van. We're kind of working toward the team-based care model. I'm the OT nurse, and the docs come in and kind of talk to the client with me rather than having to move the client through the clinic, which is working great. I wanted to ask how you streamline the social work part, because I know we have one social worker who's just slammed. And so when we need something kind of short notice, it either throws her day off or she's just not available. And how did you guys address that?
Sure. I think with our social worker, it was also a challenge we were having in our primary care to include our social work in the care we were doing. The social worker we worked with, Terry, was really great in that if we looked at a client and looked like they might need some social work support, we'd connect with her before a visit. So we kind of just increased that pre-visit communication to kind of put it on the table that this person might be looking for support, gave the clients the option to check in with her at that time, or maybe she could see them later in the day. But it was really about that communication piece and trying to make it work for the client.
So I'll just add that our social worker, when they were doing team-based care with us, they weren't booked for the whole day. So I'm not sure if your social worker has appointments, every hour or however. So they had slots open for kind of drop-in. And that's how we were really able to make that work. And the other thing is, in speaking to that communication, we did use EMR Messenger. So that can get really distracting, so you need to be careful with it. But because we don't have this co-located charting space that we would like one day, our social worker's down the hall and pretty far away. So usually we would just send a quick message, do you have time to see so-and-so? And then they would let us know either way.
Just to follow up, the co-located charting is essentially come out of the exam room to chart so the exam room is available for somebody else.
Exactly, yeah.
Quick question. Do you think you're working harder or working smarter, seeing more patients?
Really good question. Initially working harder. So to be honest, it's a big learning curve and it's a big change. And so we were working hard. We were hustling. But definitely once things start to get moving and you see those efficiencies and you build the relationships amongst the team members with the patients, it's definitely faster and smarter. Yeah. But it takes time. And we're still not there yet, necessarily.
Any other questions? Of course.
My question is around high-functioning teams. Can you tell me like 2 or 3 things that you think have made your team high-functioning?
I think one of the things is, at least within our group, we were all really excited about team-based care. We wanted to do this. It was, we built it. It's kind of our baby. And so we were really invested in the work we were doing. And I think that made us work so cohesively.
Yeah. And then the challenge becomes, like we've talked about, how do you spread that? So in terms of the high-functioning teams, I would add, speaking about the psychological safety, I think that's really key. And I think that one thing that we miss, whether it's health authority or private clinics or anywhere else, is investing in building those relationships and that culture of safety. It takes time and it takes funding, and we need to be willing to put that into these programs, and we'll see the benefits in the long run. But it is a cost up front that I think is a bit of a barrier sometimes. And then trying to lay ground rules, like we've seen, and making sure when we got together and we were first in the recruitment stage of the pilot, we sat down and we said, we want to be able to disagree respectfully, and we want to be able to share ideas, and anything goes, and this is a safe space. Yeah. I don't know if there's anything to follow up for that. I liked actually your answer about psychological safety too. I think you said it really well, yeah.
Thank you for the presentation. It's really amazing. I'm just curious, like all the work that you have done, how do you foresee it spreading to different clinics, different settings?
Oh man, good question. It's a challenge for sure. One of the things that we realize is it's no longer something that we can all do off the side of our desk, and so fortunately we've recently been able to get a project manager that's hopefully going to help us spread. Even within our own clinic, we still haven't spread to everyone in our own clinic. There's momentum, we're all talking about team-based care more and more with the patient medical homes and primary care networks, and so there is support, but again, it takes a dedicated role to really see it through. And within Vancouver Coastal Health Community Health Centers, there is another practice at Ravensong that's doing team-based care already, and that was one of the places that we went to for support and ideas when we got started. So it's there, and all of senior leadership is on board. It's just a matter of giving, again, the resources to see it through. It really requires project management.
Thank you very much. And that concludes our session. Thank you very much for attending and joining us. And, oh yes, fill out evaluation forms.
But if you're using the app, I have a specific way to do it. You go to your program overview, you select the session in question, and on the details side, there's a plus sign. And if there's an evaluation, there will be a clipboard there that you can click on to fill out your evaluation online. Has everybody got that? If not, and you want to do it the old-fashioned paper way, please fill it out, and Leslie's at the back to gather them. Thank you.